Much, Dr. Mohamed-Naguib. I want first to thank you for the invitation and congratulate you and all Qasr Al-Ainy team for the excellent organization and this terrific event. The program is amazing and I'm enjoying watching it, and with all the team, young fellows and all professorial team. I want to say just a special hi to Professor Akasha. He's there. It's very nice to see you again. And I hope, as you said, all to meet face to face then in the next event, inshallah. So my task is to talk about IgG4 disease-related pancreatitis. Why I have chosen this topic? Because there were some new guidelines released, European guidelines published in 2020 in UEG journal, covering all the GI-related IgG4 involvement actually in disease. So it covers from pancreatitis to biliary tract to GI tract. So I picked up just pancreatitis because it's a very interesting topic, and I'll walk you through what is the management, diagnosis and management of pancreatitis, IgG4 related pancreatitis through a clinical case. Just first things I wanted to say, just a reminder, IgG4 related disease is a chronic inflammatory sclerosing and fibrosing systemic disease that can involve pretty much all the organs in the human body, and specifically GI tract, with the special involvement in pancreas and biliary tract with cholangitis, and also digestive tract, but it's a lesser extent. And the main other organs involvement are lacrimal glands, maxillary glands, lymphadenopathies, and retroperitoneal fibrosis also. So this is a very tricky disease because it mimics a lot of other diseases. It is characterized by mass forming. So in all these organs, swelling and mass forming is typical findings. So it can be confusing sometimes, and other diagnoses can be evoked in front of those clinical situations. It is a dangerous disease because in every and each organ it involves actually, it causes fibrosis, inflammation, chronic inflammation, fibrosis, and subsequently organ failure. So in terms of pancreatitis, I will just walk you through this clinical case, and we'll see together all the particularities of diagnosis and treatment. So my patient is named Salah. He was 36 years old when he first came to our department. He was a former smoker, and he used to use alcohol for a couple of years before he stopped 3 years prior to diagnosis. He presented actually with chronic epigastric pain, atypical, not typical to pancreas, with massive weight loss, but really rapid at the end of its evolution. It lasts actually for a year, the whole symptomatology. And he presented with the recent onset of diabetes. He presented no diarrhea and no other symptoms whatsoever. His BMI was 18 at entry. He presented no jaundice. He had a vitiligo that was not diagnosed before. He presented no lymphadenopathy and no other organ swelling at a physical examination, namely no splenomegaly or hepatomegaly. And his biology tests, the lab tests, were normal for the blood count. Liver enzymes was slightly elevated for the cytolysis, but cholestasis was moderately elevated for gamma glutamic transferase. His bilirubin was normal, and albumin was 36 grams per liter. And his fecal elastasis that we have actually looked for afterwards, after we knew that there was a pancreatic involvement of a disease. Fecal elastasis was really very low, showing exocrine insufficiency. In other laboratory tests, we found out rheumatoid factor to be positive, but nuclear antibodies were negative. His imaging, first line imaging techniques and findings were ultrasound and CT that showed a diffuse pancreatic enlargement, and the radiologist directly went to MRI to characterize this MRI findings, So I'll just share with you the pictures of the MRI, and you can already see some very interesting changes here. In the T2 weighted sequence here, we have a swollen pancreatic gland in two sites, bifocal actually swollen of the pancreatic. I will go through the details maybe later. And the neck of the pancreas was pretty much normal, with a visible duct that is not visible in all the other parts of the pancreas, and namely in the head, and also the tail and body. In the MRCP, actually the CBD in distal CBD was very narrowed, but without dilation in the upstream, and there was a thickness in the wall of CBD, but also the MBD was completely vanished and really slightly visible in some parts, but the rest of the gland is completely vanished besides the neck of the pancreas. So when you have this kind of findings, can we evoke or consider IgG4 pancreatitis? What are other diagnoses that we can think of? How to confirm this IgG4 suspicion? What are indications for treatment, if there are any? What are the options for treatment, and what response to expect? These are the questions that I try to answer for these patients. So can IgG4 pancreatitis be considered? Yes. Knowing all the characteristics in imaging, it could be considered in these patients. So for clinical and biological features, actually there are absolutely non-specific, but knowing the epidemiology of the disease, is he really sticking with the epidemiology of the disease? Really no. He's not in the regular median age, because it's usually the 6th decade. He was younger for this, but as you all know, there have been also children and adolescents reported to have this kind of involvement and diseases, so it's not something that is completely atypical, but it was not in the normal range of age. He's a male, and it is a disease that is really with the male predominance. His symptoms were not consistent also, but they were possible, but knowing that it's non-specific features. He had chronic epigastric pain, which is really present in the pancreatic involvement. Acute pancreatitis have been reported. They are usually mild, not severe pancreatitis, but the main symptoms actually of pancreatitis involvement is painless jaundice, and it is reported to be up to 65%. The weight loss he presented is consistent also with the exocrine deficiency, and not specifically with the disease, but also in IgG4 related disease in all its involvement, in all its organ involvement, and can be also accompanied with slightly weight loss. The really onset of diabetes short before the diagnosis is also something that is completely classical. Up to 50% of patients have a simultaneous onset of diabetes. Considering the laboratory test, the usual laboratory test, actually nothing is specific in all this, and the liver enzymes abnormalities can be consistent with the obstruction in bile ducts and the slight narrowing without dilatation above. And he had a clearly exocrine deficiency, and the rheumatoid factor is also reported to be positive in IgG4 disease, up to 20 to 30%, and antinuclear antibodies are also sometimes elevated up to 30, and some series it was almost 60%. Some other lab tests and usual lab tests abnormalities that can be also found regularly in IgG4 pancreatitis, but also disease in general, are elevated eosinophilic count and IgG elevation. So in terms of clinical biological findings for now, it's not really typical of IgG4 pancreatitis. But does the other findings consistent? Imaging actually, in fact, in this patient was completely consistent. I'll skip the US and CT just for sake of time, but US is, I love US in general and EUS, and it is a super useful tool, and all the abnormalities and the typical findings in imaging that are described in IgG4 pancreatitis can be seen in ultrasound, actually, if it is well made. And CT also can find a lot of typical imaging features of IgG4 pancreatitis, and actually it's the same in all findings, and it is two types. The first type of imaging typical findings is parenchymal modifications, and they are enlargement of the gland, and this enlargement can be multifocal or rarely actually multifocal, but usually it's a diffuse enlargement, up to 50 to 70%. It's diffuse enlargement and the sausage shape pancreas. It can be focal sometimes, 30% of patients. In our case, it was multifocal. It was body, tail, and head. Typically also there is a delayed enhancement and at a really delayed phase, and it can be also patchy and focal enhancement in early phase, but it increases with the time, and it's a delayed enhancement at the end. There is the typical rim-like enhancement, and it's edema actually and around the gland, and we can see it actually in the picture here. And the intensity is completely different around the gland. The loss of lobulation, this is also typical. All these findings we can see actually in our patient's MRI, and they are consistent with typical imaging of IgG4 pancreatitis. The duct changes are also very interesting to see, because usually there are long segment involvements and sometimes multifocal. And what is really interesting to observe here is the narrowing and sometimes the complete vanishing of the ducts in the imaging without any upstream dilatation, and that is very important sign that make all the difference with the pancreatic cancer, that we cannot find this kind of findings, because when the duct is completely obstructed, there is always a dilatation upstream. Skip lesions is also typical to find in our patient. This was the case. We had this bifocal involvement in the gland, so we had vanishing of the MPD in 2 areas, and it was visible only in the neck. The icicle sign also is consistent with this disease, and it can be observed whether for biliary duct or a pancreatic duct. And in this case, we haven't the picture yet here, but it was the case for the biliary, the CBD, a distal CBD. And we can see that there was a cholangitis, a focal cholangitis in the pancreatic segment of CBD. So in our patients, actually, the imaging was typical. But is it enough? Do we need more information? Are there any differential diagnoses at this stage? Should we rule out pancreatic adenocarcinoma anyway? So yes, we need more information. It's not enough according to guidelines and according to all other diagnoses and possibilities of diagnosis. Actually, at this stage, I just go back to the imaging. In our practice, we would evoke other diagnoses. In our context, tuberculosis is something that we evoke really regularly in inflammatory masses. So in a patient like this, we could evoke tuberculosis. The non-consistent sign here is the lack of lymphadenopathies and other involvement of organs consistent with tuberculosis. Lymphoma could be also evoked here, but the bifocal finding is not typical of lymphoma, but the swelling of the gland sometimes and also can evoke a lymphoma of the pancreas. So serology, is it of any help? It is typically IgG4, serum IgG4 that we will look for, and the elevation is also something and a very, very important sign that we have to consider. Are there any cutoffs to help us interpret this serum IgG4? Yes, in guidelines, actually a serum IgG4 up than 140 milligram per deciliter has a very good sensibility and a very high specificity, so it is used as a cutoff. But in the ICDC criteria, you will find twofold upper normal for IgG4 serum IgG4 to be considered as major criteria. In our patient, the serum IgG4 was 190 milligram per deciliter, so it was also another very major, very important criteria to consider for the diagnosis of IgG4 pancreatitis. Are there any better serum markers? Yes, there have been a lot of studies showing that other markers could be used in this case to elevate actually the specificity and sensitivity and to help us diagnose and specify and also differentiate IgG4 pancreatitis, but more the studies were more done with cholangitis to differentiate actually cholangitis from cholangiocarcinoma and PSC. So the ratio IgG4, IgG1 was well studied in cholangitis, and it's really interesting marker, but it's not validated yet. Other markers like IgG4 PCR clones and qPCR IgG4, IgG RNA ratio were also something that is really developing, but it's not validated clinically yet. Circulating plasmoblast and CCL18 is something that is coming also and need more validation and more studies to come. So for now, our patients, we have really two major findings that are consistent with IgG4 pancreatitis, the imaging findings and the serology findings. Is endoscopy of any help at this stage? Actually, it's not necessary, but the use actually of endoscopy is two things we can do. EUS is a very fantastic tool. For diagnosis, it's not mandatory to have EUS, but when it is indicated to have a histology and a sampling, a tissue sampling, yes. Namely, when we want to differentiate IgG4 from pancreatic cancer, it is mandatory to have a histological proof that to rule out actually pancreatic cancer. But when the involvement of the gland is diffuse and the imaging is typical, we have elevated IgG4 serum, we will see that in the criteria. We don't need specifically the histology, but it is mandatory to have tissue sampling, I just repeat, to rule out pancreatic cancer, especially when it's a form mass, actually a form that is a mass forming IgG4 pancreatitis. In our patient, it was a diffuse involvement on the gland, but it was very interesting findings in EUS, which is completely typical too. It was enlargement of the gland with very super hypoechoic signal of the gland on EUS. The ducts was completely vanished. We couldn't find the typical ductitis and thickening of the wall in MPD in EUS, but it was more a mass forming, but it was bifocal and very diffuse in the body and tail. We have performed EUS, but we couldn't have at the time the IgG4 immunostaining, but it helped us actually rule out pancreatic cancer just because we were completely stressed with this mass in the body and tail of the pancreas. So when it comes to EUS, for diagnosis and for ruling out under tissue sampling, which needle would we use? Actually, it has been shown that 19 gauge needles could be a good help and give actually a good sensibility, but the 22 FNA needles were really fine and the sensibility was 60%. Actually, there are really recent publications in endoscopy showing, comparing actually different types of needle in this indication. And they have been shown that the new FNB needles and specifically the fork type needles have increased the sensibility to up to 70–75%, even 79% for some studies, compared to the 20 gauge bevel needles, but also to other FNA needles. So yes, maybe in this indication, it is advisable to use FNB needles to have as much samples as possible, specifically for IgG4 immunostaining, but also to rule out pancreatic cancer. Other type of endoscopy and tissue sampling that can be helpful for the diagnosis is the biopsy from the major duodenal papilla. That can be helpful also if we perform IgG4 immunostaining. So once we have this tissue sampling, are there any histological really characteristic features that we need to pay attention to? Yes, of course. We have this criteria, and you already probably know the four main findings actually in histology that are consistent with the IgG4 pancreatitis, and it is different from actually autoimmune pancreatitis type 1, which is the IgG4 type, and the autoimmune pancreatitis type 2, which is completely different, and the findings are completely not the same. So typically IgG4 pancreatitis, it is a lymphoplasmocytic sclerosing pancreatitis, showing four main features: the lymphoplasmocytic infiltration, which can be diffuse or patchy, the storiform fibrosis, the obliterative phlebitis, and specifically the IgG4 positive cells that has to be for the criteria, and the cutoff is more than 10 cells per HPF for biopsy sampling. But for actually surgery specimens, it has to be more than 50 cells per HPF. And you know that sometimes we have surgery specimens because up to 5 to 8% of duodenectomies for mass, for pancreatic mass, have findings consistent with IgG4 disease. So the ratio, also other histology findings or other histology features that should be paid attention to are the IgG4 IgG ratio on histology, and it has to be more than 40% to be consistent with the diagnosis, and we can find usually also some lymphoid follicles. So in our patient, we had lymphoplasmocytic infiltration that is fine, but the IgG4 immunostaining, as I said, we couldn't perform at that time. Other organ involvement, it's typical, and it is very rare to have isolated pancreatic involvement. It is sometimes a sequential involvement of organs and not all organs involved at the same time. So with pancreatic involvement, it is usually up to 90% of cases actually accompanied with a biliary involvement. Kidneys are involved in 35% of pancreatitis actually involvement too. And in our patient, actually, if you have paid attention before, in the MRI I showed you, he had the swollen kidneys that was bilateral, homogeneous, and with all typical findings of kidney involvement in IgG4 disease, which is the multiple low density areas predominantly distributed in the renal cortex, and it is commonly bilateral, and it was the case in our patient. And in terms of biology, his renal function was normal, but he had a urine proteins that were elevated actually, and it was 0.5 gram per 24 hours. So it was kind of something that was actually motivated and more motivation for treatment, and I'll talk about this later. Lacrimal and salivary glands is usually involved also in this disease. In our patient, he had a biopsy of salivary gland that showed fibrosis and all histological features consistent with IgG4 disease. Aorta could be involved, retroperitoneum, lungs, and meninges. But as I said, orbital and other involvements are always possible and have to be looked for actually systematically in those patients. It has been also proposed to perform PET scans with FDG scans to just look for all involvement at once. And it is very high, not very high, but 10 to 13 SUV when it comes to PET CT. Do we have to exclude other diagnosis? Of course we have, and the main diagnosis that is really an issue is the AAP versus pancreatic cancer. And as I said earlier, it is very stressful when we have a mass forming in the pancreas and we have to rule out pancreatic cancer. So histology here comes of necessity to be able to rule out, but we have some morphology and imaging features that can help us differentiate, but they are not completely typical. So we have to perform histology to rule out cancer. CI-1099 is something that can be used, but it is not sensitive enough, not specific enough to rule out cancer. So in our patient, it was normal. I'll move quickly. I will really skip the international consensus that you probably all are aware of, but I'm just wanted to remind you of all the specific features. And there is a consensus for diagnosis for IAP, and for type 1, it is definite or probable, including all the features that I've told you about, including histology, including imaging, including serology, including response to steroids, and actually other organ involvements. I haven't came yet to response to steroids, but I can do it right after. It is 2011 guidelines, and they are still actually the only validated criteria for diagnosis. There are other criteria in the Japanese guidelines, but also in the Mayo Clinic guidelines that are consistent and the same features are used. So the criteria, the histology criteria, I've already told you about. I was put this on the slide just to remind it if I had time. So I'll just skip quickly since the time is going by. The serology criteria and other involvements and other ongoing involvements. So response to treatment is very important because sometimes we could not prove the IgG4 involvement of an organ, and this is another tool that we can use to have more criteria for the diagnosis. And steroids are used actually, and it's very, very rapid response and very high effective drug actually for this disease. So for our patients, we confirm the IgG4 pancreatitis based on all the criteria I've told you about, imaging, serology, and other organ involvements. Is there any indication for treatment, and what treatment and what response to expect? I just want to remind you that there were European guidelines that have been published recently, including all digestive involvement. So I'll just try to sum up the algorithm for this from these guidelines. So the indication for treatment is clear. Symptomatic patients have to be treated, but asymptomatic patients can be treated in some involvement and some conditions which are a mass forming and persistent mass in the organ, persistent cholestasis when cholangitis is there, and subclinical situations that could lead to organ failure. In my patient, it was more the kidney involvement that were in us along with the pancreatic involvement. So which treatments to choose? First line treatment, validated treatment is still corticosteroids, and the dose is from 0.6 to 0.8 milligram/kilogram per day for 1 month, 4 weeks. The higher doses can be used in some patients in overweight, etc., and lower doses can be used in some frail patients with the we are afraid that they will not tolerate the glucocorticoids. The tapering has to be slow. This is key actually management. It doesn't have to be fast tapering of corticosteroids because relapse is the main issue here. So we need to taper very, very slowly, and it could go as long as 6 months tapering. So whether the patient is responding, which means they have a decline in IgG4 levels, during the steroid therapy were 15%, steroid tapering reaching a dose of 10 milligrams for maintenance, and no relapse during the tapering at least at 6 months. This is the indications actually to start the treatment and to follow out the patient. Relapse, when it comes, we can use corticosteroids again, because the first line treatment with steroids, it could have a response to up to 97 to 100% response. And when we reintroduce again the steroids for reinduction of remission, it has also a very high effectivity, and it is up to 95%. So we can use again the corticosteroids with a higher dose, with a longer and a prolonged period, and a even slower tapering. And we can also, Japanese series and Japanese guidelines also suggest a maintenance dose of steroids for years, actually for at least 2 years. We can use actually rituximab also in this situation when we have a relapse distant to the first course of treatment. In case of intolerance or non-response or relapse during the 3 months after the beginning of the treatment, or we have high risk of relapse, I'll get back to the high risk factors. We can use directly rituximab at a dose of 1,000 milligram infusion at 2 weeks, at 2 weeks apart every 6 months for 2 years. That is the schedule that can be proposed for rituximab, and also another schedule that can be used also for rituximab with 375 milligram per kilo per infusion. We can also have the option to add immunosuppressive agents. All immunosuppressive agents have been tried in this indication. Azathioprine is one of the main used ones in this indication, up to 2 to 2.5 milligram per kilo per day. In case of no response for immunosuppressive agents, in case we have added immunosuppressive agents, we can move to rituximab as a second-line treatment. What are for our patients, actually, we did this, steroids for 4 weeks, very slow tapering along with the nutritional support and pancreatic enzymes. He had a very rapid clinical improvement, no pain. He had also urine proteins that have been negativated after 6 months of treatment. He gained weight, he went back to his normal life, he normalized all biology tests and decreased in serum IgG4. So we were very happy with the response, and the follow-up now, it's 5 years, and he presented no relapse. But the relapse is a very major issue in this disease. As I said, the glucosteroids are really effective, but the relapse is up to 26 to 70%. It's a very big gap in the numbers from Asian series. It's very high relapse rate. In European series, it's a little lower. Relapse risk factors are really not well defined, but the ones that have been consistent in literature are higher serum IgG4, persistent high serum IgG4 after glucocorticoids course, multiple organ involvement, and cholangitis have been actually consistent in literature to be as a risk factor for relapse. So maybe in those patients, we should be careful to keep steroids as long as possible and to taper it really, really very slowly, and maybe higher dose of steroids at the beginning. And as I said, reinteraction is very effective. So how do we evaluate response? There is this IgG4 related disease response index that is really complex, that is especially used in clinical trials, but in practice, as guidelines say, we can use physical examination laboratory, usual laboratory tests, imaging, histology, and IgG4 serum levels to follow up the patients and assess actually response. So for conclusion, I'm sorry for the time, IgG4 pancreatitis is the usual revelation mode for IgG4 related disease. The major issue is pancreatic insufficiency, but other organ involvement can be actually of a very prognostic value. And the main issue is to rule out pancreatic cancer, especially in the focal form of the disease. Glucosteroids are really very effective drug, and the relapse is a major issue. And other therapeutic options are mainly rituximab. So thank you very much for your attention and a very warm hi from Wujda team. And I just wanted to remind you of this app if you are not aware of. This the GI guidelines, the app that is available for free on all stores, that is really featuring very interesting interactive algorithms that we can use. And we will put more guidelines in it really short time. Thank you very much.
You can send me the link of it and I will post it on the Telegram group and the WhatsApp group and the Facebook page.
Okay, I will.